Assalamu alaikum wa rahmatullahi wa barakatuh. Well, it's honor and pleasure to be here and every time in Nephrology, our home. And the subject have been chosen actually by the scientific committee to address this new topic or relatively new topic and the new updates in the field of onco-nephrology being a developed subspecialty of nephrology. Going to the slogan of nephrologist, medicine is not a branch of nephrology. Medicine is a branch of nephrology, actually. Nephrology is the mother of medicine, and this would be proven now in how nephrology interacts with all specialties. To start with, I'm just paving the way for the next three speeches, which are delivered talks by our international guest speakers from around the world. And I'm not going to address the subject in depth because it's far beyond the scope of the time, but just to have a view of what's going on in onconephrology. It's actually changing from just tumor lysis syndrome, where you have a high uric acid and you need to give the patient fluid and alkalinization, versus doing dialysis or withdrawal some nephrotoxic chemotherapeutic agent, and that's what was the previous idea of AKI in oncology patient, to having all these aspects, managing AKI and CKD in patients with cancer, CKD from total or partial nephrectomy in a patient who developed an RCC or another type of urological cancer, and CKD from paraproteinemia, which we have addressed previously in the last Nephro Alex in the 10th one in a whole session, and kidney injury due to therapy, which is now not only chemotherapy but chemotherapy and target cancer therapy and immune checkpoint inhibitor, as we will hear in this session inshallah, and then severe fluid and electrolytes abnormality induced by drugs or others, and dosing and timing of chemotherapy, missing the dose and missing the cycle of chemotherapy because of high AKI, and the burden of this on survival of a patient with cancer. So it's a multifactorial, it's a big issue, and we are in the core of this. And just to start with, the prevalence of renal impairment with the GFR less than 60 milliliter per minute is between 12 and 25% in around the world in cancer population, between France down to Japan, and in big cohorts of patients between 5,000, 1,000, maybe 200 patients. It's always consistent, having a big issue with the renal function. So it is the cancer, what it do to the kidney? Well, it can cause AKI or CKD, and the AKI can be related to the therapy itself, whether this is radiation or hematopoietic stem cell therapy, a chemotherapy, conventional one, a targeted cancer cell therapy, or a nephrotoxin like in antibiotic and non-steroidal and other adjuvant therapies that are being given, or by immune checkpoint inhibitor by immunotherapy. In the core of this is the tumor lysis syndrome and TMA that can occur by many factors, may be related to cancer itself. This can be a paraneoplastic disease like in glomerular syndrome, membranous and others, FSGS and others, lysozymuria, direct invasion by a tumor or infiltration by hematological obstruction, as Professor Salah showed us, either in or out or from the lumen obstruction, as we'll see. Metabolic effect may be mediated by hypercalcemia, or hemodynamic effect mediated by sepsis or dehydration and having ATM. And as you can see, that the risk of AKI after cancer diagnosis in the first year is 18%, and in the first 5 years is 27%, and you have a summative incidence of 40% of critically ill patients with cancer will require renal replacement therapy. So it's a big issue, and it affects both ways. And the causes can be hemodynamic, pre-renal, or injury due to the cancer by TMA or diet infiltration, or a paraproteinemia or obstruction, or injury due to metabolic complication as in TLS and hypercalcemia, or by drugs as we mentioned earlier. And if you look here, there are patient-centric factors and there are cancer-specific factors. And you have to address all these types of risk factors that can increase the incidence of occurrence of AKI in those patients. The age of the patient, you have to mind, the baseline renal function, the comorbid condition, the nephrotoxic adjuvant therapies like antibiotics or non-steroidals or anti-inflammatory. And regarding the cancer itself, is it a renal cell carcinoma after a patient had a nephrectomy? And that's why we prefer partial nephrectomy rather than complete whenever it's feasible. Hematological malignancies have a special predilection to be precipitated in the kidney and causing infiltration, myeloma with different types, leukemias and lymphomas. Obstructive nephropathy can occur, as we will see, from within, without, or from the lumen itself. HSCT can cause many effects on the kidney, and the hypercalcemia, and the anti-cancer drug, and the tumor lysis syndrome, and the neutropenic sepsis from bone marrow suppression by agents. Again, these can be renal, extrarenal, or post-renal, or pre-renal. Pre-renal with a hemodynamic defect. Intrinsic renal can be tubular, glomerular, or vascular, and the post-renal can be obstruction, and the obstruction is not only a lymph node that's obstructing the ureter, it can be a drug that causes crystallization from inside the tubules of the kidney. And in the pre-renal, these are risk factors for occurrence of pre-renal renal impairment, including the use of ARBs and ACE inhibitor, maybe the SGLT2 and other diuretics, and many other etiologies that can cause depletion. And we've been referring to this as a sick drug list leave, which you would take out from a patient who is critically till he is stabilized, and then you can give it back to him, as we've heard early with the cardio session. Obstructive can be intratubular or extratubular or even postrenal. This can be by direct tumoral invasion or bladder outlet obstruction, or even a trigonal obstruction to the ureteric outlet bilaterally with a cancer bladder. It can be retroperitoneal lymphadenopathy or even a retroperitoneal fibrosis by effect of radiation or some drugs even. And definitely some drugs can cause the increasing incidence of renal calculi as well as the tumor lysis syndrome and others. And the extrarenal effect can be due to a blood clot or fibrosis, or even a BK virus that can cause urethral obstruction by sloughing. And the intratubular precipitation of uric acid or a light chain or drug-induced crystals like in high-dose methotrexate, or even with some antibiotics like ciprofloxacillin and others, can cause crystallization and intrarenal tubular effect. The thrombotic microangiopathy is a little bit different, whether it can occur due to the tumor itself or to the chemotherapy itself. And there is no response if it is a tumor to the plasma exchange. It can be helpful if it is a chemotherapy induced, especially with ADAM-TS reduction if you use the plasma exchange. And the paraproteinemia, we've been to it the last year, as we've mentioned, but you should know that it affects every portion of the nephron. It's not only the glomerulus. The glomerulus can be affected by paraproteinemia. The proximal tubule can have LCPT or light chain proximal tubulopathy, and then you can have the cast in the distal tubule, and you can have a free Pence-Jones with no effect, just to discover that the patient has a paraproteinemia. And if you go further, for the AKI unrelated to the paraprotein, it can occur from the hypercalcemia or volume depletion or tumor lysis syndrome or acute urate nephropathy, else than other effects that we've just mentioned by the paraprotein. And these are effects of paraprotein on the kidney. I don't know why the quality of the slide. Can we please have some adjustment for this? But these are types of what can occur in different parts of the kidney affected by the paraprotein, whether glomerulonephritis MIDD or PGN MID or light chain glomerulopathy or even cryo and C3 mediated MPGN. Tumor lysis syndrome is a special issue that would be addressed by Dr. Mithri in this session later on, and I'm not going to go through, but still the Cairo and Bishop criteria are there to address early diagnosis of tumor lysis syndrome by clinical and laboratory issue. And the treatment-related AKI is widely spread, using chemotherapy and using, as we've mentioned, immune checkpoint inhibitor and using target therapy. Going from AKI to CKD, there is a big issue of having chronic kidney disease in a patient with cancer. There are cancer-specific risk factors that causes chronic kidney disease, not acute, like paraneoplastic syndromes, like hypercalcemia, like tumor infiltration, urinary obstruction, and glomerular disorders, and that is irremittable. And there are patient-specific risk factors, the age and the comorbid condition, diabetes and heart failure and others, and the baseline renal function. And as we've come to know that AKI is not an innocent issue that goes to home safely, it usually leaves an imprint on the kidney. And when a patient had AKI, there is a higher incidence of progression to CKD in his later life. And there are cancer risk factor or cancer therapy factor that can cause permanent irreversible damage to the kidney as well. And for survivors of cancer, the incidence of having chronic kidney disease is there. So those people survived cancer already. If they survived cancer in childhood, there is absolute incidence of 0.5%. So 1 in 200 would have end-stage kidney disease in future life, although he survived cancer. But with exposure to nephrotoxic chemotherapy, this can lead to nephron loss, and this is, as you know, not regenerating. Increased risk of AKI can cause as well increased loss, and there is an incidence of 4 to 5% in elderly population who survived cancer, specifically when you have a stem cell transplant or HCST. And there are many paraneoplastic syndrome related to the kidney, mainly affecting the glomeruli. It's not membranous nephropathy as per the classical teaching. It's every type of GN can occur as secondary form of neoplasm. For example, IgA nephropathy can occur with mucosal affection, whether in the respiratory tract or the gut or the buccal mucosa. Membranous nephropathy, the classic one, with lung, gastric, renal cell carcinoma, prostate cancer, and CLL. And minimal change disease can occur with Hodgkin, and also it can occur with the non-Hodgkin and some leukemias and lymphoma, and even in colorectal cancer. FSGS can occur with renal cell cancer, with breast cancer, with thymoma, and again with Hodgkin lymphoma. And PGN occurs with paraproteinemia and other hematological malignancy. And crescentic GN can occur with gastric and lung cancer. So each and every type of glomerular pathology can be secondary to cancer, and you have to look for. And you have to look for the clinical and pathological clues in the biopsy that can help you to say whether this is a primary or secondary. For example, adult minimal change disease should be taken seriously, in contrast to childhood minimal change disease. In membranous nephropathy with age over 65, it is an obligation to do a cancer workup. Some literature say even if the PLAR is positive. But anti-PLAR negative and THD77 negative is a must to exclude malignancy in a patient with membranous nephropathy. In FSGS, with no obvious primary pathology, like it's not nephrotic, it's not heavily proteinuric, and it's not severe edematous and hypoalbuminemic patient, which between brackets mostly primary, so you have to exclude malignancy, especially in elderly patient and other patients. So this is part of the story. The other part is how the kidney affects the cancer, not only how the cancer affects the kidney. Actually, there have been literature about the increasing incidence of cancers in patients with CKD. So we have to observe our patients. They might be at a higher risk of cancer, and these have been shown in many studies. Not only this, how to assess the GFR in a patient with cancer is a big issue. For example, Cockcroft-Gold is almost an obsolete to be used. The PSA adjusted CKD API GFR estimation is the best, and even it's better than the cystatin creatinine based CKD API in cancer patient, because cancer, as you know, thyroid dysfunction and steroid use affect the cystatin level, so it wouldn't be accurate in this situation. Of course, the MDRD is not the best thing to use as well. But you have a lot of drugs that need to be adjusted according to the GFR. So you have to calculate the GFR properly for each patient. And this is the issue of assessing the kidney function. Very brilliant slide, actually, just released a couple of years ago. Functional, which is glomerulocentric assessment of the kidney function, and structural, which is tubulocentric affection of the kidney function. And here, starting from the Cockcroft Gold, the old one that is not so much valid, going to the MDRD, CKD API, CKD PSA adjusted API, and the newer one, the Janowitz and Williams EGFR. And now, what was Professor Yasser just telling us, kidney on a chip or intravital microscopy, go inside the kidney with an intravital microscopy, or renal reserve tests like Professor Salah Naga has been telling us, like the challenge test or the kidney stress test by the LASIX and others. Okay, and if you go for the tubulocentric effect, and GAL and NAG and interleukin 18, KIM1 and others, and maybe the IGF binding protein 7, all these have been used and they are still on board, like with the NephroCheck and other models, to try to find out a proper method to address the kidney function. And that's what was I saying, that the risk of cancer increased with the occurrence of CKD and GFR. And I would just give you at last, these are to be covered by the next talks, but I'd like to leave you with these KDIGO points. Just again, a very fresh look. The controversy conference on the onco-nephrology, understanding kidney impairment and solid organ malignancy and managing kidney cancer. And this table is just, all these are unanswered questions in the field of onco-nephrology, addressing the renal function, the cancer screening, preventing of CKD or AKI, the nephrotoxicity of agents, and the managing of a specific kidney cancer. All these points are points to be addressed by further research. And this is just to show you that we are just in the beginning of crawling in the field of onco-nephrology, and there is a yet lot to be told and hopefully learned in the future. Thank you.